separate out into two layers of cells, an outer layer and a middle layer, which we call the blastocyst. And then from there, this divides further and separates into three layers of cells called the gastrula. Now, this is where most of the discussions about cardiac and organogenesis will be focused on. So this is also another look at the same images I've shown previously, where you have a zygote that goes through a number of cleavages and divisions into a bag of cells that separates into two layers and then subsequently into three layers, the gastrula. And when you look at this same structure from the top, this is how it looks like. This, what you see as a cross-section of this structure here. So the gastrula is the starting point for all formation of organs, and that's really important in the discussion that we are going to have. So essentially, if you look at this structure, okay, the three layers we have here, from the top, it looks in this way. This is the gastrula that we have, shaped in this manner, with a cranial end and a caudal end. And if you cut through the structure, you have three layers of cells, okay? 1, 2, and 3, the blue, the red, and the yellow. Okay, so this is the gastrula that we are talking about. Layers of cells are what we traditionally know as the endoderm, the mesoderm, and the ectoderm. Okay, and the cardiac organogenesis primarily occurs mainly in the mesoderm and portions of the ectoderm, even though the regulatory factors that influence these two layers, some of them come from the endoderm. So essentially, you have all these three layers of the gastrula are involved in cardiogenesis. Okay, so gastrula in cross-section, three layers, the mesoderm, and the ectoderm. And the bulk of organogenesis, as far as the heart is concerned, is in the mesoderm. Another view of it. So just the same thing, the process of gastrulation from a two-layer cells into a three-layer cells, where you have the outer ectoderm, the inner endoderm, and then the mesoderm. When you cut the gastrula, which is like a tadpole in cross-section. Some people are hungry at this time, so this is not to tempt you, but just to also highlight the same thing. So this is how a gastrula will be shaped like, okay, in the fetus, just in the middle of it, okay, around the thoracic cavity. You have the top layer, the middle layer, and then the outer layer, okay? And so if you cut this into cross-section, those are these structures, just like you are cutting your section. So this section here, which is the mesoderm, is where most of the cut is being formed, where you have the green leaves and the onions. This will be the ectoderm and then the endoderm. So now we've moved into the mesoderm. And once in the mesoderm has three parts: the paraxial mesoderm, the intermediate mesoderm, and the lateral plate mesoderm. So you're looking from middle to outer, okay? And at the outermost layer portion of it, which is the lateral plate mesoderm, you have two other layers. And one layer of that forms the parietal mesoderm, and the other is the visceral mesoderm. So cardiac organogenesis occurs in the splanchnic mesoderm or the visceral mesoderm. So first the gastrula, the mesoderm, the lateral plate mesoderm, and then finally the splanchnic mesoderm. So this is how it looks like. I've already talked about the three layers already: the ectoderm on top, the red being the mesoderm, and then the endoderm. And then when you look at the mesoderm from middle to outer, you have the paraxial mesoderm, the intermediate mesoderm, and the lateral mesoderm. And it's in this portion of the lateral mesoderm, the visceral portion, is where the heart cells originate from. So essentially, cardiac development occurs in the cranial part of the gastrula, in the lateral plate of the mesoderm, and it goes and it's formed from a process of myocardiogenesis and vasculogenesis. So we'll focus on this image here, the gastrula, which I originally described to you, which I said had a head and a tail. Okay. And this is looking at it from the top. So you have cells, mesodermal cells that move with pregenital cells that move to the head part of it, the cranial part of it, and form a crescent cell over here. So that is where cardiac morphogenesis occurs, at the cranial portion of the gastrula in the mesodermic layer, specifically the lateral mesoderm. That sets us where we're actually going to build the heart from. Ultimately, we know that the heart formation involves complex signals, and these signals interact with each other. And these signals, what they essentially do is to look at the whole cells that we talked about originally and program some of the cells arising from the zygote to be specifically programmed to develop into the heart and specific aspects of the heart. Okay. And once these cells are programmed to focus on building the heart, they come together to form a heart tube, which loops and divides into the complex heart that we have. So it's almost like going to build a house. Okay. You have a lot of materials you can use. Okay. But then right from the onset, you decide that I'm going to use these materials for the roof. I'm going to use these materials for the foundation. I'm going to use these materials for the doors. I'm going to use these materials for the pipings. Okay, so those are the signals and the specification. Once you make those decisions, then you can actually start building your foundation. You build the walls, and then you build the roof, and then you have a full house. So essentially, that is how the heart is programmed as well. So this is one image that over the years has really, made me have a good understanding of the processes as well. So like I said, there are cells which are the prepotent cells, and they are programmed to form the mesoderm. And these mesoderms are programmed to form the cardiac mesoderm. And the cardiac mesoderms are programmed to form three important structures: the first heart field, the secondary heart fields, and the epicardial cells. And these cells develop into specific aspects of the final heart that we have. So the first heart progenitor will develop into left ventricular cardiomyocytes, atrial myocytes, and cardiac conduction tissues. So if you have a child who has issues with conduction, heart blocks, WPW problems, you know where the problem may have arisen from, that the first heart field may have had a problem, which led to poor development of the conduction tissues and thereby leading to your conduction abnormalities, or any of the other cells there and what they do in the process. Okay, so that is what we talk when we say that cells are programmed for specific purposes. And then what we see here, the BMPs and FGFs, activin and nodal, they are the signals. These are the signals that tell the mesoderm to specifically change some of its cells into a cardiac mesoderm. And some of them can actually inhibit the process and some can activate the process. Okay. So with this sets the tone for actually the building of the heart. Like I said, in the building of the house as well, the things that you do at the beginning sets the process into building the heart. Importantly, we know that all these processes occur in specific timelines. We know that the heart is the first organ to form and function during embryogenesis. And that's because by the time the embryo gets to about the third week, the nutrients that it obtains and the oxygenation it obtains by diffusion are not enough to sustain its metabolic demands. So at that point in time, it requires a functioning fetal heart to begin to do the pumping as well. So right from day 22, we begin to see the first heartbeat of the primitive heart. And then by day 28, we have a full active circulation. So we'll go back um, diagram again, okay? And the specific timelines as indicated, so that by the time that we get to day 23, we have a primitive tube that is formed and begins to show pump, blood around. So we've set the foundation for the actual early cardiac development. So the phase one, what I call the phase one of early cardiac development, is what I've spoken of originally, as in cardiac tissue specification, the body deciding that out of its pluripotent cells, these cells will be committed to developing the heart. Okay. And once that is done, those cells come together at the cranial part of the gastrula to form two important tubes that we call endocardial tubes. These tubes fuse together to form a heart tube. The heart tube undergoes cardiac looping to orient itself, and then it septates and then undergoes trabeculation. Okay. So the first in the cardiac tissue specification, this is an organized process. It's very organized, but it's not random. And the signals that usually trigger the formation of this specification of cells for building the heart itself are usually what we call the mesoderm posterior 1 and 2 triggers. This is important in this transferring the pluripotent cells into mesodermal cells. Doing that, it stimulates other agents which help to either induce the formation of the heart or limit the extent to which the heart is formed, because you don't want to have excessive cardiac tissues all over the human body. And so the inducers will program these cells into this pathway, but it has to do it in such a way that the cells do not overshoot their boundaries, and then you begin to have myocardial tissues all over the place. Okay. Now, common errors that can happen in this mesodermal posterior site is that if you have excessive tissues being formed, then you have ectopic cardiac tissues so you have the heart forming in other out of the main thoracic cavity. Or you can have a very complex abnormal cardiac morphology and function. So that, for instance, instead of the first heart field, programming left ventricular myocytes, it may end up programming right ventricular myocytes. So you have a right ventricle that is formed, but is not functioning effectively as you expect the right ventricle to be formed. Or the left ventricle is formed with tissues that are not programmed to deal with systemic vascular resistance. And so with time, it begins to fail. Okay. So those signals are quite important. So after these cells have been committed and devoted to building the heart, then the next thing is that they now have to get into the business of shaping themselves into the heart. So the cells aggregate at the cranial part of the gastrula, and then they develop myocardial cells in two forms. The first myocardial cells that are formed are the first heart field, and the second myocardial cells are the secondary heart fields. So these are myocardial tissues that bow together to form two distinct hollow tubes. And the inner part of them are lined with endocardial tissues. So together they form what we call an endocardial tube. These two tubes then fuse together to form a primitive heart. And the primitive heart is a straight tube, but we know that the heart is not a straight structure. So then, due to the processes of vasculogenesis and angiogenesis, blood flows through these tubes and bends and turns this tube in a way that makes them malleable and eventually form the final shape chambers that we have in the heart. Okay. This complex process of cranial cells going through all the way to form a primitive heart are under the control of complex signals, as I spoke already. And these signals regulate every part of this process. So if these signals malfunction, every part of this process may develop problems, okay? And we'll find specific pathologies that arise because some of these signals did not function properly. So this is what we've been talking about. The cells at the cranial end of the gastrula, they form two distinct tubes, okay, from the first heart field and the secondary heart fields. And then these tubes join together to form one continuous tube. They are straight initially, but due to the flow of blood through them, they obtain their contours, and eventually they end up with the primitive heart tube, which is well lobulated with chambers that are programmed for the final chambers that we have in the matured heart. Same simplified in this form. So two tubes from the original cells, okay? The first heart field and the secondary heart field individually produce these tubes. They fuse together, okay? The top part is formed by the secondary heart field, most of the lower part by the first heart field. In fact, the bulk of the final heart is produced by cells originating from the first heart field. Okay, so this is where we got into. And so the well-lobulated primitive heart has all these segments, and each of these segments are programmed for specific parts of the final heart. So you have the sinus venosus, okay, which develops into part of the atrium and the systemic venous system. Then the primitive atrium part, which develops into the atria, the primitive ventricular part, which develops into the left ventricle, the bulbous cordis, which develops into a big portion of the right ventricle and portions of the left ventricle as well. And then the outflow tracts, which develop from the truncus arteriosus. So this is a bit more elaborate, and I said most of this already. The sinus venosus with the venous return to the heart, the atrium part to form the most of the right and left atrium. Then you have the ventricular component, which forms mainly the trabeculated part of the left ventricle. Then the bulbous cordis, which forms most of the right ventricle, portions of the left ventricle, and moves into the truncus arteriosus, which forms the ascending aorta and the pulmonary trunk. So what are the common errors that can occur? There's the heart that this is what we are discussing, how the first, and usually I said that there are signal transducers that program each portion of them. The tubes are formed from myocardial cells from the first heart field and the second heart field. So if you have an abnormality with the TBX20, then the cardiac morphology will not be formed properly. And so you end up with a heart that does not contract as well as it should contract because of the deficiencies in TBX genes. And the TBX genes or signals there are quite a number of them, as I highlighted here previously. You find them a lot involved in a lot of genetic syndrome like the Georges, Noonans, and so on and so forth. So now we formed the cardiac, primitive cardiac tube or primitive cardiac heart. And so the next thing is for all those segments to loop into their final place. And this usually occurs in the 4th week. Okay. And so the heart loops in a rightward looping manner where the initial posterior aspects of the heart move a bit more anteriorly. And these are also under a lot of control of signals that we're talking about. Okay. So the focus will be on this lower part here. So you have the first heart field and secondary heart field, which through all the processes we talked about end up forming a tube. And like I did indicate, most of the heart is formed primarily from the first heart field. Okay. Only a small portion, a bit of the anterior part and a little bit of the posterior part are formed from the secondary heart field. And so this is our primitive heart, and it has to now undergo some looping where it's rightward in this anti-clockwise fashion, okay, in this manner. So these portions from the first heart field go anteriorly, and then these portions from the secondary heart field come more posteriorly. Okay, so that places the atria where they are and the ventricles a bit more anterior and as you see here, and then the atria a bit more posterior. Same description illustrated here. Okay, so the mid portion is rotating rightward here, the posterior aspect going anteriorly, and then the anterior portion coming a bit more posterior. Okay, to simplify it a bit more here, this, like I said, secondary heart failed, the first heart failed, which forms the bulk of the heart. It starts looping, and the looping brings the more anteriorly positioned secondary heart failed, which forms the truncus arteriosus, a bit more portions of the truncus and the bulbous coming this way, and then you have the mid portion going more anteriorly. So what are the common errors that can occur with the loop? Okay. And the normal one is when you have a D loop. So you can see here the normal pattern here, the D loop where the bubbles cord is moves rightward, okay, and the ventricles moving a bit more superior. So then that leads us to the normal anatomy where the aorta is posterior to the pulmonary artery and a bit to the right of it. Okay, but if the looping becomes abnormal, then you have a more anteriorly located aorta to the right and a posteriorly located pulmonary artery. And in that case, then you end up with the transposition of the great arteries. Okay, you could also have the same thing. Okay, but in this time around, the pulmonary artery is more to the right of the posteriorly located aorta, which is an inversion form of the normal one. But then you could also have a situation where the aorta is anterior to the pulmonary artery, but to it's more positioned to the left of the pulmonary artery, and then you have an LTGA. So as right after cardiac looping occurs, then you need to have a trabeculation of the ventricles because that is important in the final ability of the ventricle to contract. Okay, and then also helps with the conductivity as well. So within the chambers, myocardial tissues flank out of it into laminar folds, and these laminar folds are covered with endocardial layer. Okay, so they spring out like you have with some uh, regular grass where you have all the grass leaves fanning out. But that is not enough to create a good contracting ability of the ventricle. So after trabeculation is compaction. So this brings all the cardiac myofibrils a bit closer to each other so that they can work together and produce an effective contractility. Okay. So this is what eventually gives us the trabeculated and compacted ventricles that we have with our hearts. And this is also under the control of the NOTCH1 gene. If this gene is abnormal, then what you have is that you have a non-compacted ventricle, okay? And you find out that because this NOTCH1 is also involved in other parts of the embryogenesis, is involved in cardiac septation. So you may have a child who has a ventricular septal defect, but then if you look carefully at the myocardium as well, the myocardium may be non-compacted. So in addition to having a significant left right heart shaft region, you have a heart that is not contracting properly because it's non-compacted. If you do not identify the non-compacted nature of the ventricles, then you will not appreciate the severity of the symptoms that the child is experiencing. Or better still, you may go and have your surgery and close the VSD, but then you're still left with a non-compacted LV, which will give you more problems. So the child does not recover as well as you want them to recover. Okay. At the end of the first phase of our project, our building project, what we've expected to happen is that original bulk of tissues, some are separated to form cardiac tissues. And those ones that are separated to form cardiac tissues are programmed to form specific cardiac tissues. Okay. So eventually they go and form the cardiac myocardium, which forms the endocardial tubes, which fuse to form our primitive tube as well. We also expect conductive tissues to be formed. The outline of the future chambers to be formed through the lobulation of the tube, and then eventually the dual loop of the heart. So from there, we move to phase two. And phase two, specific structures are being formed. Okay, where specific structures are being formed. An important part of the phase two is where our pharyngeal arch, and we know the pharyngeal arches are the arches that form a lot of the arterial structures within the body. They are not part of the heart tube, but at the beginning of this phase of developmental structures, these pharyngeal arches connect. Okay, they connect to the truncus arteriosus portion of the heart tube, because those are what are going to form the head and neck vessels. Okay, and a lot of the process of heart structures involves cardiac neural crest cells, which migrate down into the thorax, into the heart tube, to help with septations, formation of valves as well. Okay, and an important part of the final heart is the septation of the chambers in the outflow tracts, the development of valves, the development of head and neck vessels, the systemic venous, the carving of the heart, and so we'll go quickly to the atrial septum. So the atrial septation, the ingredients for atrial septation are the septum primum, septum secundum, and the cardiac cushion, and then the fetal blood flow. And these atrial septations is under the control of the TBX5. Okay, part of the TBX genes are listed over there. And the TBX gene you find common in genetic syndromes like Hot Oram and Ellis-Van-Creveld, which is why these syndromes are associated with either a common atrium or various degrees of atrial septal defect. So Hot Oram, we know, I mean, you would either have various forms of ASD, and the same thing with, okay. All right, so let's see how these ingredients play out. So this is our atria, unseptated atria. At the middle portion of the heart, we know is a mesenchymal tissue that we all commonly refer to as the endocardial cushion. Okay, it sits right in the middle of the heart, and it's important. It's an important structure for the formation of the atrial septum, ventricular septum, and the atrioventricular valves. The absence of this tissue is what gives us the atrioventricular septal defects. Okay, so the first step in the septation of the atria is invagination of cells from the roof of the atria, and these cells are called the septum primum. Okay, the septum primum. So they begin to develop downwards, and their target is to get to the endocardial cushion so that they can just separate it one off. But if you remember fetal circulation, you know that blood is also coming from the fetus, okay, IVC, and across from the right to the left side. So if this was just to continue unabated, then you kind of shut off blood supply from the right to the left. So while the septum primum is getting all the way down, the blood flow from the fetus builds up here. So cell necrosis occurs within the septum, causing perforations within it to allow for some blood to flow from the right to the left. And so that leaves a room within the original septum primum. Okay. But the septum primum continues to grow until it reaches the endocardial tissue here. But it is left with a hole in this portion, and that hole is what we call the foramen secundum. Okay, it is left open originally, but then soon after, another septum originates also from the roof of the atria, and this septum grows as a flap to cover the defect, the foramen secundum that was left over there. So this is what you are calling your foramen ovale, and this is where you are calling the flap of the foramen ovale. So as soon as pressures in the left side increase after the fetus is born, the lower part of this tissue is adherent to the septum secundum to completely septate the atrium into a right atrium and a right and a left atrium, and that is the final destination. Okay, so take note of the importance of the endocardial cushion, the invagination from the roof, the perforation to allow for continuous blood flow between these two chambers, and the eventual occlusion of that chamber in a flap valve. And then you have the final septation. So what can go wrong? So the things that can go wrong in this process is that this tissue may never reach the endocardial cushion. And if it never reaches there, then you end up with a defect here, which you'll call the premium ASD. These flap valves may never be adherent, so you may end up with a patent foraminal valley. Okay. The perforations here may get bigger, and then you will never have this septum secundum forming to close them up. So you end up with a secundum ASD. Okay. So this is the same thing I've described in a more detailed manner. Okay. Invagination from the top going to the cushion, fetal blood flow still going through and creating perforations in the septum premium. That creates a hole in there, and then the septum secundum comes as a flap to close it up completely. So the errors in the septation of the atria will lead to a premium atrial septal defect, a secondum atrial septal, a persistent foraminal valley, or a common atrium in some situations. Okay, so that will be for atrial septation. Please, if at any point in time you have any question, you are free to stop me. So we go to ventricular septation. Once again, the endocardial cushion is very important in ventricular septation. In addition, there's an interventricular septum which is also involved. And the neural crest cells are primarily also involved, especially when you get into the outflow portions of the ventricles, because the ventricles tend to have an inlet component, an apical component, and an outlet component. So if you are dividing the ventricle, you must divide it from the inlet, the apical, as well as the outlet components of the ventricles. And that's where the neural crest cells also play a role. And this septation is under the control of the TBX1, which we know is an important gene as far as the judge is concerned, and the PTPN11, also important in Noonans. So it's not a surprise that when you have genetic problem abnormalities with TBX1 and PTPN11, you end up with VSDs. So the judges end up have VSDs, Noonans also have VSDs. Okay, and this is because of the role of these genes in ventricular septation. So the focus will be on these images. Okay. All right. So we have the endocardial cushion in the middle of the heart, like we saw previously. Then the interventricular septum invaginates from now, not from the roof here, but from the apex and goes upwards. And its target is to reach the endocardial cushion. Okay. It keeps going and going until it reaches the endocardial cushion. Okay, so if at any point in the journey from here to here, the process is arrested, you have varying degrees of ventricular septal defect. So if the process is arrested here, you'll have a large muscular VSD, okay, and then an inlet VSD, and okay, as you can see from here. If the process goes all the way and arrests just before you get to the endocardial cushion, then you will end up with an inlet VSD, okay, which is why we say inlet VSDs are a component of the endocardial cushion defects because they arise because the interventricular septum did not reach the endocardial cushion, okay? So that is how you end up with this form of VSD, okay? But also bear in mind that during the same process of the septation, there's a lateral invagination of the myocardium also towards the same endocardial cushion. And this lateral invagination is what ends up forming the tricuspid valve and the mitral valve. Okay, if these processes are affected in one way or the other, then you have abnormally formed tricuspid and mitral valve, and which is why you end up having valvular abnormalities and endocardial cushion defects. So commonly when you have a complete AVSD, you have a premium ASD, and inlet VSD, and then you tend to have abnormal atrioventricular valves. Commonly, you may end up with a cleft in the anterior mitral valve leaflet. Okay, and all this is arising from just the fact that all these tissues did not reach their targets, which is the endocardial cushion at the heart, at the center of the heart. So the common errors we can have in ventricular septations are that you may have a univentricle, that's a ventricle that was not septated, or an unbalanced ventricle. Okay, so typically when you have endocardial Cushing defects with the ventricular component of the defect, you will find unbalanced ventricles, and commonly you find that the right ventricle is hypoplastic. Okay, and that has implications when you go and close those defects, because you close the defect and you have ventricles that are uneven and they cannot co-contract as they ought to. Okay, you also end up with varying degrees of ventricular septal defects, especially the muscular and the membranous, as well as the inlet. So I've spoken a bit about this already, the AV septation and AV valve formation. And the components are the mesenchymal tissue on the lateral sides of the tissue, the endocardial cushion, the interventricular septum, and the septum primum. So I'll go back to this. And so we start from here, and I talk about the lateral imagination of mesenchymal tissue going towards the endocardial cushion. And that is what forms the AV valves, okay? And also divides the atria from the ventricles, okay? So we see the significance of the endocardial cushion in the formation of ASDs, in the formation of VSDs, in the formation of AV valve abnormalities, and in atrioventricular septal defects. Common errors that may occur with the endocardial cushion as far as the atrioventricular septum is concerned is the premium ASD, inlet VSD, and cleft in AV valve leaflets. So from there, we've done the atria, we've done the ventricle. So now we're going to the outflow tract. So the first portion of the outflow tract involves the ascending aorta and the main pulmonary artery, and they arise from the truncus arteriosus to the primitive heart tube. Here, okay. So we are in this portion now. We've septated here, we've septated there. So we're now entering this section. Okay. So we are here. Okay. And the division of the outflow tract is not as straight up down like we have with the atria and the ventricle. If you look at the atria and the ventricle, the septation is up down or down up, but the septation of the outflow tract is spiral. Okay, it is spiral. So, and it's almost like having a spiral kind of staircase, and separating, two portions of a home. Okay, and this is the reason why you have the aorta and the pulmonary artery crisscrossing. Okay, they don't go from up to down. We know that the pulmonary artery starts off from the right ventricle and is more anteriorly, starts from the right, ends up on the left, and then bifurcates. While the aorta starts from the left ventricle, crosses posterior to the pulmonary artery towards the right shoulder, and then it arches mostly on the left, across the left bronchus, and then descends. Okay, and this arrangement is because of the spiral nature of the septum that septates them. So if there's a problem with this spiral nature, then you can imagine that you'd have malaligned great vessels, which creates all kinds of problems. It's also important to note that because the outflow tract are connected to the ventricles, the spiral septum must be connected in one way or the other to the interventricular septum. Okay, so you have a straight up interventricular septum and a spiral septum, but they must connect to each other so that the ventricles are committed to the appropriate great vessels. And once again, the neural crest cells are so important in outflow tracts, okay, septations. And this process is regulated by a number of genes like NOT2 and JAG1. And if you remember Alagille, these two genes loci are important in the Alagille syndrome. And that is why you find an Alagille, you end up with pulmonary stenosis, okay, because this is an outflow tract issue in addition to the hepatobiliary problems. This is what I've tried to capture in this images. Okay. So the septum is spiral. So it allows the pulmonary artery to start off from the right and end up on the left, and the aorta to start from the left and end up on the right. Okay. And this gives you the characteristics overlap of the structures. So the aorta, the pulmonary artery is anterior and to the left of the aorta, was you have the aorta being posterior and to the right, but arches on back onto the left pulmonary artery. And that is because of the septal septation. I also mentioned that just before the septation of the great arteries, you have the aortic arches or the pharyngeal arches, okay, joining the truncus arteriosus to form the head and neck vessels. We'll talk about them a bit more later. But for now, this septation is only the septation of the truncus arteriosus into the aorta and the pulmonary artery. So I'll give a classical example. So you have the aorta and the pulmonary artery, the right and the left ventricle. So the right ventricle must connect to the pulmonary artery. The left ventricle must connect to the aorta. The spiral septum that separates the aorta and the pulmonary artery must align with the straight interventricular septum to give us what we normally see: blood flow in this direction, blood flow in that direction. But if the spiral septum does not align with the interventricular septum, then you can see what's going to happen here. Okay, there'll be a narrowing of the pulmonary artery because this spiral septum was shifted anteriorly and to the left. Okay, so it narrows the pulmonary artery. So all of this becomes the aorta. Okay, and then this ventricular septum is no longer aligned with the spiral septum. So there's a huge gap between them, and that creates a VSD. Okay, and because of this huge aorta now, it overlies both the right ventricle and the left ventricle. And so you have the characteristic problem of a tetralogy of Fallot. And the problem primarily with tetralogy of Fallot is because of the problem with septation of the outflow tract. This spiral septum just was not aligned with the ventricular septum. And so pulmonary stenosis or pulmonary atresia, a large VSD, an outlet VSD most of the time, a dilated aortic root, which is overriding the right ventricle and the left ventricle. Okay, so this is a classic error septation. So if the truncus arteriosus does not septate, then you have what you call the truncus arteriosus, a common trunk. If it septates preferentially to the left, then you end up with the tetralogy of Fallot. And if it septates preferentially to the right, then it narrows the aorta and end up hypoplastic left heart syndrome. Okay, and most of these rise the TBX genes and NOTCH1 and right. So we've septated the atria, we've septated the ventricle, we've septated the truncus arteriosus. Okay. So now we formed our right and left atria, right and left ventricle. We formed the ascending aorta and the pulmonary artery. But then we know that beyond the main pulmonary artery and the aorta are all the arch and the head and neck vessels. Okay. So the pharyngeal arches, like I said, are different from the heart tube. They are structures that also form embryologically. They are a bunch of arteries. So they end up connecting to the truncus arteriosus at the top through an aortic sac, and then through the processes of the neural crest cells, are able to develop into various aspects of the head and neck vessels, either because they involute or they join other structures. And the extensive process is regulated by NOTCH1 genes and the TBX1 genes in DiGeorge. Okay. And so once again, you will appreciate why in DiGeorge you end up with VSDs, you end up with other tetralogy of Fallot, truncus, condotruncal abnormalities, and then you end up with interrupted aortic arch. That's because this single gene is involved in septation of the ventricles, is involved in septation of the truncus arteriosus, and also involved in the formation of the aortic arches and branches. So classically, this is how I'm sure you probably would have seen this online somewhere. I love this picture so well because when I was confused, it helped me out a lot in the past during my training years. Okay, so this is how the pharyngeal arches are. Okay, a series of paired arteries. Okay, superior to the heart tube, but they are connected to the heart tube by the aortic sac, which is okay in this region here. Okay, and through various processes, they end up involuting or joining each other to form the head and neck vessels. It looks like a complex process, but actually still a mirror image of one same thing. Okay. This is your original truncus arteriosus, which has been septated to form the ascending aorta and the main pulmonary artery. Okay. And then it is connected to these blue portions. Okay. Your pharyngeal arches. Okay. Now, the beauty about this image is that it tells you that the aorta, from the ascending all the way to the descending, arises from different embryological tissues. Okay, different embryological tissues, and we'll find out soon enough. So this is another of the same, but this one with more label. So the aorta is initially formed from the septation of the truncus arteriosus into the ascending aorta and the main pulmonary artery. But beyond that, the first part or the proximal part of the arch, okay, is formed from an aortic sac. And this is what I was referring to here. This middle portion, these are a balloon portion called the aortic sac. Then the mid portion of it here, this small section, is from the fourth pharyngeal arch. Then the purple part of it is from the dorsal aorta. If you come back to this image, this is your truncus arteriosus, which forms the ascending part of the aorta. Okay. Then you have the dorsal aorta, okay, which forms the proximal part of the arch. And then the fourth pharyngeal arch, which is here, forms the part of the arch between the left common and the left subclavian. And then the green part, the descending part here, is formed by the dorsal aorta. So if you have a genetic problem that affects the fourth pharyngeal arch, then you are going to have an interrupted aortic arch. Okay. An interrupted aortic arch, you have a type A, type B, and type C. And depending, if you have a problem with the dorsal aorta, then you end up with the interrupted arch on this side here. And if you have a problem with your dorsal aorta, then the interruption will be here. Okay. And that is why when it comes to the aorta, you have so many pathologies. Okay. You have truncus arteriosus, you have hypoplastic, you have coarctation of the aorta, you have interrupted aortic arch, you have vascular rings from double arch, okay, and so on and so forth. And that is because of the number of embryological tissues that are involved in the formation of the arch. So the take home from this particular section is that your truncus arteriosus forms the ascending aorta, your aortic sac forms the proximal aorta, your fourth pharyngeal forms the portion between the left common and the left subclavian, and then the descending is formed from the dorsal aorta. Okay, so you have the fourth, the aortic sac, and the dorsal aorta. And then the sixth pharyngeal arch forms the left and the right pulmonary artery. Okay, and these are things that are required of most trainees when it comes to head and neck vessels. Okay, the fourth pharyngeal arch the sixth pharyngeal arch, the aortic sac, the dorsal aorta, okay, are really important. So what are the common errors? The interrupted aortic arch, vascular rings, okay, double aortic arch, aberrant subclavians, the slings, okay, all because of problems with that complex. So we have only 3 minutes. So just to capture everything we said in this image here, we've said so far. We've talked about gastrulation. Okay, we've talked about the secondary and the first heart field going to the cranial aspect of the gastrula. They form the heart tubes. The heart tubes together form a primitive tube. Blood flows through the primitive tube to, locate it into chambers. Okay, and we said the primitive tube is made up of, the bulk of it is the first heart field, and the small portion of it being the secondary heart field. Okay, and then the primitive heart begins to beat, undergoes a looping process that is rightward, the D loop, and anterior. Okay, so it brings the anterior structures a bit more to the posterior portion, and the posterior one a bit more to the anterior structures. Okay, and once that is done, the looping is done, neural crest cells migrate into the heart to help with septation of the heart. The atria is septated, the ventricles are septated, the outflow tracts are septated as well. But an important part of all of this is the addition of the pharyngeal arches, which form the head vessels. And we said the important takeaway from those pharyngeal arches is that the aorta arises from many embryological tissues: the truncus arteriosus, the aortic sac, the fourth pharyngeal arch, and the dorsal aorta. And any problem with any of this can give us the various types of interrupted aortic arch, vascular rings, aberrant subclavians, and so on and so forth. Same process and another image. I love this image as well. So once again, your tube being formed, okay. The head and neck pharyngeal joining the truncus arteriosus, like I said. Okay, then septation begins. Okay, septation of the atrium from the septum secundum and the septum primum. Lateral invagination to form your AV valves, and then the intraventricular septum from below to form the intraventricular septation. Okay, and then from there, with the septation, the spiral septation of the truncus arteriosus to put the pulmonary artery anterior and to the left, and the aorta posterior and to the right. Okay, and we talk about the fact that that spiral septum must align with the interventricular septum. Okay, to avoid having VSDs and tetralogies and truncus arteriosus. And then finally, we talked about the head and neck vessels arising from the pharyngeal arches and the importance of the aorta having different origins: the truncus arteriosus, the aortic sac, the fourth pharyngeal arch, and the dorsal aorta. And with that, we can end here, and then we can talk about the rest tomorrow when we have another session. So I'll pause here. If there's any questions in the little time left, I'm happy to take it.
Good evening, Dr. Josie. I am very happy you accepted the invitation. I know the schedule you run, so I couldn't join earlier on, but to the team, let me take the opportunity to really introduce Dr. Delajosi. He's a boss at my workplace. He's a pediatric cardiologist, and he does more than pediatric cardiology. In fact, very soon he's wooing me to become an adult congenital, and he's been very supportive towards training and also improving the knowledge of adult cardiologists in adult congenital. And he's a one-man show. His entire team is on leave. Some have traveled, and he's literally holding the fort with one medical officer and some surgical senior residents, and I've pulled him here. And on behalf of the team, Dr. Josie, I want to say a very, very big thank you for making time out of your busy schedule, because I know the schedule you run, and to be with us this evening. And we are very, very grateful. I just thought I should say this before we take the questions. Thank you very much.
Thank you very much. Thank you very much, Dr. Jesse, for such a wonderful presentation. I like the way you broke everything down, and then constantly you kept going back just to make sure we're on the same level with you. Embryology is always difficult, but the way you've done it, I was able to follow everything, and now some concepts that I was finding very difficult to understand there. It's very clear to me now, and I guess the same thing is happening with all my colleagues. We are very, very grateful for this opportunity. Please, at this point, we would await your questions. You can type or unmute and then ask your question.
Sorry, I think I went over at some point, but I'm sure I didn't miss much there. Sorry.
Oh, Dr. Josie, you didn't miss much. It was me saying thank you for taking these topics to help the team. And I know the busy schedule you run, and I know where you were that I've pulled you this evening to do this topic. And I'm very grateful. Thank you very much. I don't owe you one. I owe you 1,000.
Thank you so much too. I'm sure you said more than this when I was off, but knowing you, that's fine. Yeah.
Thank you very much. At this point, I would call on our consultants if any of them is on board.
Hold on, please, for the consultant. Thank you, sir, for the presentation. You made it a bit much simpler, and with those diagrams also made it a bit simpler. Just want a little clarification, sir. So from the gas relation, which tends to happen about around that 14th week, it seems to be this question about the time you exactly have the first heartbeat. I think you showed the slide, but you took it up very fast. I think around 23, 25. I'm just trying to be sure of, can we put it to a particular day or maybe a range of 1 to 2 days, just to have something to guide us?
Okay, so I don't know whether I'm still sharing the slide, but the it's usually, like I said, by the 21st day, the heart is ready. It cannot survive on just diffusion. Okay, so usually the first heartbeat is on the day 22 of the gestational cycle, day 22. Some books will say 23, but by and large, 22 is a safe bet.
Thank you, sir.
I hope yes. So day 20, 22. Yeah.
Thank you, sir.
You're welcome.
Please, any more comments?
Okay, thank you, sir, for the very detailed presentation. We are grateful, sir. It's about the first and the secondary heart field. Please, sir, can you go by it? I didn't really get that, sir.
About what?
The primary and the secondary heart field, how they fuse together to form the tube, sir.
Okay. So let's say the first heart tube and the secondary, so the first heart field and the secondary heart field, let's say they are like, okay, you're going to build 2 pillars for a house you are going to build. Okay, so you have 2 categories of sand and cement mixtures. So the first the sand is the first Hartfield, and the cement will be the secondary Hartfield. So you mix them up in reasonable proportions. Okay, in this case, like I said, most of the heart is from the first Hartfield, so you may have more sand than cement. Okay, and then you use them to build two different pillars. But then eventually, when you now want to start the building, you want to bring these two pillars together to form one big pillar, or let's say a block. Okay, maybe the block is a better analogy. You want to build the wall with two blocks. So the block is a mixture of cement and sand. So you build block one with a mixture of cement, which may be the first Hartfield, and sand, which is the secondary Hartfield. Then you build another block with the same mixture of first Hartfield cement and secondary Hartfield sand. Once you've built these two blocks, now you want to bring them together to build your wall. So you bring the two together, and then those two together now form a wall for you. So the individual blocks are the endocardial tubes from your sand and your cement. When you bring them together with mortar to form a wall, then you have now formed your primitive heart tube.
Okay, sir. Okay, thank you, sir.
Yes.
Sorry, sir. As a follow-up to that question, Sam, some talk about, I think, angioblast, which form vessels at that point when the heart is also being formed, just to incorporate that into the answer.
Yes, I mean you're absolutely right, because like I did indicate early in the early bits of it, that you need blood to flow through those endocardial tubes to make them more malleable, although just the one straight tube. So at the time when these tubes are being formed, at the same time you have the blood vessels also being formed and blood cells being formed, which then allow blood to flow through the tube to make them patent and also to make them malleable into the final shape that they have. Yes, thank you.
Thank you, sir.
Okay, please, any more questions? Okay, and unable, I can't see any of facilitators apart from Dr. Eugene. Please, Dr. Eugene, your comments.
For me, my comment is it's been a wonderful presentation. The approach was perfect. It was relatable, and it was contextualized, and we are grateful. Remember that embryology comes, our MCQs, if I remember, our first question was embryology on the heart tube. And there were some other, so please, you can go and read, and tomorrow, God willing, we'll have Dr. Josie with us again, so that if you need clarification on some things, you can quickly ask. Take the opportunity, read maybe in tonight or in the day, clarify the things so that you can come prepared and ask the questions to clarify your thoughts and improve your understanding. On behalf of this forum, once again, I want to say a very big thank you to Dr. Dela Ajosi. We are grateful, sir. Thank you.
Thank you.
Thank you so much. It's always a pleasure as well. Yes.
Thank you very much. Okay, so on this note, then we'll end here and then resume tomorrow to have another wonderful presentation with Dr. Dela. Please, the Dr. Dela, please, the time tomorrow, would you be able to start at Ghanaian time, 7 p.m.?
Godwin, I'll communicate to you. I'll talk to him, then we'll get back to you on that. Yeah.
Okay, sure. Okay. Okay, thank you very much. Have a good night.